Welcome to the Unstressed Exec, the podcast where we dive deep into the real conversations that help you lead, love, and live with greater clarity, courage, and calm. I'm your host, Dr. George Vergolias, executive coach and clinical forensic psychologist, and I help high-achieving professionals navigate life transitions, resolve conflict with confidence, and build unshakable psychological resilience. So if you're ready to lead with purpose, master conflict with grace, and become more emotionally agile under pressure, you're in the right place. Let's get started. Welcome back to the Unstressed Exec, where we talk about how to perform, lead, and live with clarity, calm, and confidence, even when life feels like it's coming apart at the seams. I'm your host, Dr. George Vergolias, forensic psychologist, executive and resilience coach, and someone who has spent decades studying how the mind, the body, and behavior intersect in real relationships, real workplaces, and real lives. Before we dive in, a quick reminder. If these conversations resonate with you and they hit home, and you want practical tools to apply what you're learning, check out my workbook, The Conflict Whisperer: From Conflict to Clarity. It is a no bullshit, clinically grounded guide designed to help you navigate conflict without losing your cool and protect your clarity under pressure. You can find it on Amazon, and I'll be sure to leave a note in the show notes. So welcome back to part 2 of our 3-part series, The Human in the Age of AI. Last episode, we examined what AI can and cannot replace in terms of empathy, attunement, and genuine human connection. Today, we go into what may be the most ethically and clinically complex territory of the entire series. We're going into the therapy room, and we're asking the fundamental question: what happens when the therapist is, at least partly, an algorithm? This episode is titled AI in the Therapy Room: Promise, Peril, and the Ethics of Digital Mental Health. I want to approach this with the full clinical honesty that it deserves. If you've been following my work, my website, my social media, and certainly this podcast, you know that I'm a clinical and forensic psychologist by training with over 20 plus years of experience in hospitals, emergency departments, the therapy room, and consulting at the corporate level with executives and senior leaders. So I really bring a clinical integrity to this discussion. And it's because the stakes here are high. We are talking about people in genuine psychological distress, people who are vulnerable, people who deserve the most rigorous standards of care that we can provide. And AI is entering this space at extraordinary speed with a regulatory framework that simply hasn't kept pace. And that is a problem. So first, let's dive into how AI is currently being used in mental health treatment. Let me give you the current clinical landscape because it really is moving rapidly. At the most conservative end of the continuum, AI is being used as an administrative and documentation tool, transcribing sessions, generating treatment summaries, flagging risk language, and essentially reducing the documentation burden on clinicians. This is relatively uncontroversial and generally useful. I think it's actually a wonderful addition because the administrative burden is something that is a hassle. It is also a necessary evil that is kind of part of the therapeutic field and landscape, but it's not something that truly leverages a therapist's true skill, nor is it something that truly helps an individual change for the better. It's just a necessary part of the process. So leveraging AI to assist and become more efficient in those areas, I think, is a wonderful development. There are still some ethical considerations to maintain confidentiality and use proper tools that are encrypted and meet HIPAA standards and so on. But again, I'm a big fan of using those tools when appropriate. Moving further along that spectrum, AI is being used to deliver structured therapeutic interventions. Apps that provide CBT exercises, mindfulness training, psychoeducation, and mood tracking in between sessions. When these are well designed and clinically validated, and when they are used as adjuncts to professional care, the evidence is that these are reasonably supportive for mid to moderate presentations. They are useful. They can be very effective when used appropriately as an adjunct to human-based clinical care. Then at the far end, and this is where I want to spend significant time today, AI is being positioned as a primary mental health provider. Chatbots that conduct what look like therapy sessions. AI platforms marketed as alternatives to traditional therapy, but they're not necessarily used as such. They're kind of used as a replacement for traditional therapy. And companion apps explicitly designed to provide the kind of emotional relationship that mental health treatment is built on. This is where I believe the clinical and ethical concerns become very serious. So, what does the research actually show here? The research on AI and mental health is genuinely mixed, and I want to represent it accurately rather than selectively. For mild to moderate anxiety and depression, well designed digital cognitive behavioral therapy tools. Cognitive behavioral therapy is also referred to as CBT, and I'll be referring it to as that. CBT, those tools have shown effects in randomized controlled trials that are meaningful, if smaller than those produced by human therapists. Woebot, for example, Woebot, has been studied in peer-reviewed research with genuinely positive results in specific populations. This is real clinical data, and it does matter. Now, again, right now I'm talking about mild to moderate anxiety and depression. Those are where digital CBT-based tools can be utilized and effective. However, for more complex presentations, we're talking about trauma, personality disorders, moderate to severe depression, acute suicidality, psychosis, complex or complicated grief, and relational trauma. There is essentially no credible evidence that AI tools are effective, and there is significant evidence and clinical consensus that they are inappropriate as primary interventions. These conditions require the full spectrum of human clinical skill: diagnosis, risk assessment, relationship repair, nuanced therapeutic judgment, coordination with prescribers, and crisis management, all of which require a human-based clinical judgment to be in play. The problem here is that the people seeking AI mental health support are not uniformly in the mild to moderate category. They are people in genuine distress across the full spectrum of clinical severity, often without access to professional care. And the tools they're accessing do not reliably assess their severity. And most of the time, and in my review, almost all of the time, they do not route them appropriately based on that severity. And that's a big problem. There are also ethical fault lines that are constantly bumped up against. As a clinical and forensic psychologist, I want to name the ethical issues here with some precision, because I think that is really important. There are 4 things I want to highlight. The first is informed consent. Ethical mental health treatment requires informed consent, full stop. The client understands what they're receiving, from whom, what the limitations are, and what the alternatives are. That's the informed part. So when you sign an informed consent document, in the document, and hopefully in discussion with your provider, these things are outlined. What are they receiving? What is the treatment? Who are they receiving it from? What are the limitations of the treatment? What are the potential benefits of the treatment? And what are the alternatives? Many AI mental health tools do not provide meaningful informed consent because they do not frame themselves as therapy or even as therapeutic. Users often do not understand that they are interacting with an AI, that the system has no clinical training, that it cannot conduct accurate risk assessments, or that their data may be used for commercial purposes. This is a significant ethical breach if a human were to be doing this under those same conditions. Second is the scope of practice problem. Licensed mental health professionals operate within defined scopes of practice under regulatory oversight with continuing education requirements, ethical codes, and liability considerations. All of this is monitored and maintained under governing bodies. Some of those are guilds for social work or psychology or psychiatry and counseling and so on. Others are licensing boards. AI mental health tools operate outside all of these frameworks. They are really beholden to no one. There are some AI regulatory frameworks that are in place. There are many more that are being proposed, many at the state level, which is a little bit of a nightmare because we could end up going in a direction where there might be 50 different statutes around what AI can do in these domains of clinical support. The president recently enacted a bill that tries to regulate this somewhat at a federal level in terms of utilization of AI in other ways. We'll see where this all lands. The difficulty is that AI systems and those frameworks, they can provide something that looks like therapy without any of those safeguards that real therapy requires. The regulatory landscape is beginning to address this. And as I mentioned a minute ago, including the FDA has issued guidance on software as a medical device. But enforcement is nascent, and the market has far outpaced the oversight. So no one is really watching the henhouse here, and it creates significant difficulties from that perspective. The other thing that I want to highlight under this scope of practice problem is the actual clinical scope. If you talk to a clinician, be it a psychologist, social worker, licensed professional counselor, psychiatrist, licensed marital and family therapist, and so on, and they tell you that they can treat any mental health disorder in the DSM, the Diagnostic and Statistical Manual of Mental Disorders, you need to run. You need to move away from that person. No one can treat all of those disorders and be a specialist. It's just impossible. It's rare that I've ever even encountered someone that claims such, but there are some. And it's okay for someone to be a generalist, but even generalists have their limitations. I, for example, in my clinical practice, I'm a generalist. There's a lot of things that I've treated over the years, a lot of conditions. And I've been able to do that because of the breadth and depth of my experience in hospitals and clinical systems and multi-state organizations at a corporate level, working within managed care and so on. But there's things I can't treat. I cannot treat eating disorders. I don't have experience. I can reliably diagnose eating disorders because of my experience working in diagnostic centers and emergency departments over many years, but I would not treat somebody with an eating disorder. It's outside my focus. If it was a secondary condition and it was being managed, maybe I would take a patient on, but I would not take somebody on as a primary issue, or if it was remotely moderate to severe in nature. It's outside my expertise scope. You're not going to see AI when you ask it a question about a certain type of syndrome or clinical condition. You're not going to see AI say that it can't help you because it's outside its scope, because it doesn't have something outside its scope. It has access to the entire internet, the entire fund of human knowledge, and it acts accordingly. But a good clinician bases their practice scope on not only their training, but also on their years of experience working with similar or the same conditions. So that's another problem with AI. In a way, it's not humble. It doesn't have the humility of knowing what is in its lane and what is outside of its lane. Third is the crisis response failure. I addressed this in a previous episode, but it bears repeating in the clinical context here. AI tools cannot conduct a genuine suicide risk assessment. It cannot make a safety plan with real accountability, and it cannot initiate emergency intervention in a way such that it really requires the human level of judgment. In a clinical setting, these capacities are not optional. They're not negotiable. They are foundational because you never know when a given client will enter or reach out to you in crisis. You just don't know. Even people you think are very, very stable could have a break and could have a suicidal event, and they need that level of engagement, that level of judgment. And their absence of that foundational understanding in AI is such that AI mental health tools represent a structural risk that has already produced documented harm. where it has either ignored the risk in some cases, that has been much often the norm. It ignored or downplayed the risk of self-harm or harm to others. In some cases, it grossly overplayed the risk, resulting in other types of harm, such as somebody being taken involuntarily to the local hospital. That has certain ramifications in people's lives. And if that's not truly clinically needed, it's a very disruptive and could be a long-lasting negative impact on their life. And the fourth kind of ethical fault line where there's a problem with AI in this kind of capacity is the therapeutic relationship as the active ingredient. I don't think we talk about this enough. Decades of psychotherapy outcome research have converged on a consistent finding. The quality of the therapeutic relationship, what researchers call the therapeutic alliance, is one of the strongest predictors of positive treatment outcomes, often more predictive than the specific therapy modality used. So it's the actual alliance itself which has more valence, more impact than what therapeutic approach is being utilized. Now, that doesn't mean the therapeutic approach is irrelevant. It's not irrelevant. It's very relevant, specific to what you're going into therapy for, but it highlights the importance of that therapeutic alliance and that it is established. This finding has been replicated across thousands of studies and dozens of therapeutic approaches. The therapeutic alliance, as it is clinically defined, requires a real human relationship. It requires trust, collaboration, genuine attunement, and a therapist who is genuinely invested in the client's well-being. An AI cannot form this relationship, full stop. And without it, the most powerful mechanism of therapeutic change is absent. A related issue for me is so much of therapy is the process in which we are understanding our cognitive and emotional patterns or loops. I like to call them loops. I sometimes refer to them as software loops. We're understanding those, but we're also understanding those most often in the context of relationships to our friends, to our coworkers, to our neighbors, and certainly to our partners and loved ones. When we are doing that with an AI system and we're not getting the reciprocity and the back and forth and the true human interaction, and I go into a great deal of this in the prior episode, which is episode 1 out of this 3-part series. But when we're not getting that, and then we have to go out into the real world and work on real human relationships with real humans, there's a disconnect. Because again, I mentioned the uncanny valley in the prior episode as well. This notion that even though AI can simulate human, it gets to a point where it's really close, but it's not quite there. And it just seems slightly off. And what I have found when people have come to me in therapy and they've tried AI-based apps and tools, and they've tried to use those to improve their relationships, there is something that is a few degrees off when they actually go back to their real human relationships. Something doesn't quite resonate. And for me, it is that gap between AI trying to simulate human interaction and humans being able to actually have human interaction. And a big part of the therapeutic process is rehearsing and working through that human interaction with the therapist, and then taking the benefits of that out into the world with real humans. That also falls under the therapeutic relationship active ingredient category here. So I've talked a bit about how the concerns rather of AI, right? And we talked about how AI is currently being used in mental health treatment, what the research actually shows, and then 4 descriptors of ethical fault lines and considerations and problems of AI in practice in the therapeutic space. But I wouldn't be very objective or fair if I didn't talk a little bit about where does AI belong in the clinical ecosystem. And I don't think the answer is to reject AI for mental health care. I talked again about this in the prior episode quite a bit. If you haven't gone back, I suggest go back and listening to that episode. Even if you're almost done with this one, go back and listen to that episode. I still think there'll be good insights. Because I make a strong case for there's a really important place for AI in the clinical ecosystem. I think the answer, though, is to be very clear about where it belongs. AI belongs as a support system, not a delivery system. That is key. It can extend the reach of human clinicians. It can reduce administrative burden. It can provide between session psychoeducation and skill practice. It can also help therapists identify patterns in treatment data. So it can help with analysis. And it can lower the barrier to first contact with mental health support. What I mean there is, let's say my clinical practice has a 3 or 4 week wait time. We know about many people that are pursuing therapeutic support, certainly for the first time. Many are not willing to wait that long. And what generally happens is there is a readiness or an openness to change that if you don't grab the person in that window of 3 days, 5 days, maybe a week, they're going to go back to their old patterns. They're basically going to say, fuck it. That didn't work out. No one could see me. I'm just going to keep doing what I did. I'm just going to get back into the day-to-day patterns of my life, right? Think about any time you thought of calling a personal trainer to get in shape and you couldn't find one. Maybe one didn't call you back. You called a few different gyms and a week or two goes by and then you just fall back into your old pattern. And you look up and it's 4 months later and you still haven't engaged that personal trainer. That is the same kind of human process that occurs for people reaching out in therapy. So where AI can be super helpful is engaging someone with various cognitive, behavioral, or other tools early on in between those wait periods. But it shouldn't replace the therapeutic human clinical interaction. But it can be useful to lower the barriers to first contact. So all of these are genuinely valuable functions. But what AI should not be doing, and what the clinical and ethical evidence does not support, is a substitute for the human relationship at the center of mental health treatment, particularly for people with significant presentations, significant risk, or significant trauma histories. I talk a little bit about this in the prior episode as well. So we're talking about moderate to severe depression or anxiety, trauma history, history of psychosis or severe mental health problems, personality disorders, comorbid problems, someone with depression and alcohol abuse, or depression and substance abuse. These are things that AI is far less suited for. Again, it can be used as a bridge. It can be used as a support system or supporting tools as an adjunct to the therapeutic process, but not a replacement for it. The standard that I would propose is this, and I talk a lot about this as my role as a chief clinical officer consulting with large corporations who are standing up mental health programs. Here's what I propose. AI in mental health care should amplify the clinician, not replace them. Every AI tool that is providing direct emotional support should have a clear and accessible pathway to a human professional. Every AI mental health platform should be transparent about what it is and what it is not. And every person using these tools should understand clearly what they are accessing. So now some closing reflections. The promise of AI in mental health is real. More access, more consistency, more reach for a system that is profoundly under-resourced. And I want to hold on to that promise because it matters for a lot of people who don't have ready access to anything else. And the peril is equally real. A vulnerable population being served by tools that lack the clinical safeguards, the relational depth, and the human judgment that mental health treatment has always required. That is a problem. Holding both of these truths simultaneously and insisting on standards that honor both, that is the clinically honest position. Two things can be true at once, and we can honor both at the same time while holding them both to a high level of standard. And part 3, our final episode in this series, we're going to get practical. I'm going to be talking about how to reclaim your human edge in an AI abundant world, what emotional intelligence means in this new landscape, and how to make it your most powerful, competitive, and relational advantage. See you there. If today's episode resonated and you're ready to continue this work, I invite you to check out my workbook, The Conflict Whisperer, From Conflict to Clarity. It's a practical, no bullshit guide to rebuilding self-trust, strengthening boundaries, and navigating relationships with clarity instead of fear. It's available now on Amazon. I'll drop a link in the show notes. And remember, insight without action changes nothing. If you're ready to turn healing into momentum and clarity into confidence, coaching can be the catalyst. You can find me at www.theunstressedexec.com or on TikTok, Instagram, Facebook, and YouTube as The Unstressed Exec. Until next time, I'm Dr. George Vergolias. Thanks for listening. And remember, shift happens.